Obstetric ultrasound trends are changing fast. What was earlier considered only as a simple dating scan has now evolved into many things. So today, we have an expert, Dr. Aniruddha Kulkarni, who is a faculty at ScholarMD, who will speak about the importance of first trimester ultrasound. Let's see what he has to say. So I have with us one of the most prominent academicians in the field of radiology, Dr. Aniruddha Kulkarni, sir.
Thank you.
Welcome, sir. I have invited you today to ask some very interesting questions, which I think are very pertinent to your field of expertise. And you're a master in first trimester ultrasound, that we all know. But I always had this thing in my mind that I'm going to ask you one day. Sir, when I learned my radiology, the ultrasound practice, what we were taught in first trimester is to measure the gestational sac and the fetal pole. But today when I see you teaching first trimester ultrasound, the kind of nuances that you get into first trimester ultrasound practice are mind-boggling. So I just want to ask you, what has changed over the period of so many years now?
That's true. We used to just date the pregnancies. Dating of the pregnancies is very important, no doubt about that. And that should be done always in early pregnancy. But not only that, the complete pyramid has inverted recently because of high frequency transvaginal transducer, which enables us to give so much of information in prior to 11 weeks of scan, where you can look at the surface rendered 3D images, and you can also look at some of the anatomical embryological landmarks at an earlier stage, so that we can comment few of the abnormalities at an earlier period of gestation by using sonoembryological technique. So it's very important that we should take our early pregnancy scan prior to 10 weeks as one of the very important detailed structured protocol-based ultrasound.
Wonderful. The second thought that always comes to me is that even today, after so many developments that have happened, so many updates that have happened in the first trimester ultrasound, the terminologies that we use are not uniform, sir. For example, we still get prescriptions where we are asked to rule out AV malformation in a post-MTP patient, whereas we regularly use the term of enhanced myometrial vascularity. So this is just one example that I'm discussing with you. Why we still haven't been able to bring about a uniformity in the terminologies that we use?
Because as an imaging specialist, we are asked to perform transvaginal ultrasound in post-MTP sequelae. So from just minimal endometrial cavity collection to retained products of conception, RPOCs, adherent RPOCs, enhanced myometrial vascularity is a complete spectrum. Now, if we do a systematic protocol-based scan with a defined terminologies which are uniform in nature, which clinician can understand, so that, let us take example, RPOCs has to be heterogeneous echo-complex area more than 12 millimeter within the cavity having intrinsic vascularity. We do not use the term AV malformation because we know that post-MTP AVM doesn't occur. It is the enhanced myometrial vascularity because of abnormal tropoblastic proliferation into the myometrial substance. Now, if we do a good transvaginal ultrasound, calculate a velocity, and you attribute some velocity, let's say 80 centimeters per second, and if there is a clinically significant bleeding PV and the velocity is very high, then definitely we will require some kind of active intervention. But in my opinion, most of the cases of post-MTP sequelae can be monitored very easily. In few patients, we might require a methotrexate, which acts as a, what you can say, inhibitor for growth of a tropoblastic tissue. And in very few patients, probably we will require histoscopic intervention or intervention for enhanced myometrial vascularity. So it's most important is using terminologies uniformly all across and following a specific protocol in defining what is RPOCs and what is RPOCs with enhanced myometrial vascularity.
Right, sir. So you addressed two things here. One thing is about the uniformity of terminologies that we were discussing about. The second aspect that you brought out was regarding influencing the clinical outcomes in the form of ultrasound findings guiding the treatment. So in your experience, how your practice has evolved over these years where you have gone from only mentioning imaging patterns in your report to actually guiding the obstetrician as to what should be the next clinical step in the form of treatment?
See, day-to-day practice, we take early pregnancy as a very casual ultrasound done. But the clinical implications as well as management options for your own case changes depending upon your own findings. So it's very important for us to understand. Let us take example of ectopic pregnancies. Now, eccentrically placed normal intrauterine pregnancy is called the angular pregnancy. Interstitial pregnancy is a pregnancy at a cornotubal junction, but there is an interstitial tube sign which is positive. And we used to say that cornual pregnancy, angular pregnancy, interstitial pregnancies are synonymous to each other, but not. When we say it's a cornual pregnancy, it is always and always in malformed stage of the uterus. So if we know and understand these terminologies and report according to that, then definitely we can say that this will grow normally as an intrauterine pregnancy because it is an eccentrically placed normal pregnancy. This is an interstitial pregnancy for which active intervention is required, and this is a malformed uterus having cornual pregnancy. So defining these pregnancies very well in early pregnancy will have a great impact on clinical outcome of the patient. So it's very essential. And not only that, as we all know, the number of cesarean scars in last 1 decade has increased by 7 times. Hence, the cesarean scar ectopic pregnancies are on a quite huge rise. Low implantation of SCACs in case of early pregnancy should be identified, and they should be categorized as either implantation at cervicoistomic junction or a cesarean scar pregnancy. On many instances, the cesarean scar pregnancy can be a heterotopic pregnancy where there is a simultaneously intrauterine pregnancy and a cesarean scar pregnancy, where ultrasound can be used as a treatment adjunct modality to treat such patient. So it's very, very essential and important that we take our early pregnancy transvaginal ultrasound very, very seriously and give sufficient amount of time so that we give a finding to the obstetrician and clinician which can be useful for management outcome.
So true, sir. There's another thing that a badly done first trimester ultrasound. In your experience, have you had cases where you have felt that had this first trimester ultrasound been done in a better way, the next ultrasound could have been done in a much better way and the final clinical outcome could have been much better?
This is very true. For the first and foremost important thing is dating. I think when we talk so much about the growth restriction, early onset and late onset, the always comparative parameter that we use is a gestational age growth, for which assigning correct gestational age is very important. A badly done assigned dating will always reflect in bad outcomes in terms of defining growth restrictions. That's very important. Number 2, if you look at the early pregnancy scan done for ectopic pregnancy, we can identify so many ectopics at earlier stage so that they can be treated on medical management lines. That is, either we can give local methotrexate transvaginal guided, or we can give a combination of local methotrexate along with a systemic methotrexate. So it's very important that whether it's a normal physiological intrauterine pregnancy or pregnancy-related complications like bleeding PV, or whether it is post-medical termination of pregnancy sequelae of RPOCs and RPOC of enhanced myometrial vascularity, or it could be an abnormal location of a intrauterine or extrauterine pregnancy. In all such patients, a good ultrasound done on transvaginal ultrasound will definitely have an upper hand in guiding clinician to give best outcome.
That's wonderful. Now, there is an increasing role of first trimester ultrasound in ruling out congenital anomalies that can be picked up at that stage. So this early first trimester anomaly scan is coming up in a big way. What is your outlook towards it, and how is ultrasound practice moving in that direction?
That's very true. That's what we call it as an inverted pyramid nowadays. Because Simon Marr version, which has recently come up in last 3 to 4 years, what he says is that there are so many structural malformation which we can get hint of in prior to 11 weeks of gestation. And there are certain surface landmarks which can be identified as a normal morphological pattern. If we say that this pregnancy is following normal morphological pattern, that means there is no features of a dysmorphism in early pregnancy. That's a huge advantage in saying that there is no major malformation at this period of time. So I think the concept of sono-embryological assessment with the high frequency transvaginal volume probe has to gain a lot of clinical significance in coming years, because we are not going to defy the embryological timeline, but at the same time this will help us to give additional clues that during my 11 to 14 week scan, what are the additional measures that I need to take and look into account, because there were certain features which were away from normalcy in prior to 10 weeks of gestation.
Great, sir. Thank you so much for enlightening us regarding the various nuances of the first trimester ultrasound and how its role has evolved over a period of years. Thank you so much.
Thank you for having me.